Our topic is differences between UK and American end-of-life care. I'm Cooper Barna, this is Alyssa Burns, and Prasanth Moku. So terminal care includes cancer, heart failure, respiratory failure, neurological diseases, and other types of chronic diseases. Euthanasia is a common practice among terminal end-of-life care. Euthanasia is intentionally ending a patient's life to relieve pain or other types of suffering. There are two main types of euthanasia, active and passive. Active euthanasia is directly causing a patient's death, specifically brought about by an act. Passive euthanasia is indirectly causing a patient's death, rather allowing them to die. It occurs via two treatments: withdrawing from treatment, such as turning off machines that help keep the patient alive, or withholding treatment, such as not carrying out certain procedures.
So the ethical dilemmas with terminal care are the moral distress type A, which is when financial complications prevent you from carrying out euthanasia. You may also have organizational policies that prevent you from carrying out euthanasia, and you can also have institutional policies that further impede euthanasia. You can also have moral distress type B, which is when the moral agent, be it the physician, the legal aid, the family member, or even the patient themselves, do not have all the information on the patient's preferences for their end of life due to their lack of prearranged arrangements. They could have like a DNR, a status, or a will. And you could also have divergent courses, which is when the patient preference doesn't coincide with the physician's objections. You can also have the patient versus family, and which results in a conflict of interest. You could also have a locus of authority issue. Who is the final decision on the patient's end-of-life care? The patient, the physician, the family member, or a combination of all three? This is also to show that the patients, the physicians, and the family all together play a role in determining the end-of-life care.
So now we're going to compare the two models between the UK and the United States of America model for the end-of-life care. In the England model, the gold standard framework is renowned among institutions, and it uses the 7 C's, including communication, coordination, control of symptoms, continuity including out of hours, continued learning, care support, and care in the dying phase. The England model also has an estimation of prognosis as highly valued, with the gold standard framework implementing a prognostic indicator guide which is used by over 90% of the physicians for palliative care. Given the choice, most patients in UK prefer to die at home, which is really great because they get to stay next to their loved ones and family and friends in their end-of-life care. This quote sums up the physicians in England very well, in that our job is to prolong life, not to prolong death. On the other hand, the United States model has the Last Acts initiative, which found that the end-of-life care in the United States of America was inadequate because most patients were suffering in pain prior to their death. Medicare and Medicaid determine a prognosis for patients with 6-month life expectancy to qualify for palliative care, so this adds another layer to the end-of-life care in the United States of America.
So when dealing with all these different types of ethical issues, we use what's called the 6-step process, which includes gathering information, identifying the type of ethical issue, using theories and approaches, finding alternatives, choosing an action, and reflecting on the decision. Step 1 is gathering information. What is the patient's prognosis as determined by a physician? What are the patient's viewpoints? What are the family's viewpoints? What is the financial situation or other types of financial burdens? What is the patient's quality of life? Are they happy? Will the patient suffer in pain? Will the treatment relieve any suffering or prolong the suffering perhaps? And then step 2 is identifying the type of ethical issue at hand. Locus of authority, who is the moral agent, the patient, the physician, a family member, or a legal counselor. You can also have moral distress type A, which is where the physician has a course of action, but institutional policies or patient's financial considerations block this action from occurring. Moral distress type B, because the patient knows the patient might be terminal, but does not know what course of action to take. Or you can also have divergent courses of action, where the patient has one view and the physician has another, which creates conflict.
So step 3 is using the ethics theories. In the United Kingdom, the physicians are encouraged to use the deontological approach, and that means that the means to get there are more important than the end goal, and the patient comfort is vital, like how most patients prefer to die at home. In the United States, the institutions encourage the teleological approach, and the end goals justify the means, and the financial and legal considerations of the patient are as important as their preferences. In the United States model, this is also shown in that more patients are in pain prior to their death in their end-of-life care. There are alternatives to end-of-life care, which are euthanasia, passive and active, hospice care, inpatient care, which can be general admission into a hospital for like a long-term period of time, and also respite care, which is short-term admission into a hospital. You can also have outpatient care with follow-ups while they're living with their family, and that can include physical therapy, health aides, and homemaker services, and it can also include spiritual and emotional counseling.
So step 5 includes making a decision. For a United Kingdom model, following the UK's gold standard framework and including the 7 C's, which we talked about before, we can make a decision, which is allowing the patient to have outpatient home care and carrying out their end-of-life care with their loved ones, including family, friends. So following the same step 5 and carrying it out in the United States model, based on patient, family, and physician preference, we can consult with the ethics committee if there's any ethical dilemma, and we must also take into account the patient and his or her family's financial considerations, and also carry out the guidelines following the beneficence and maleficence, and we can make a decision. The first of which is if the patient is terminal and the physician and or the ethics committee agree with plan to carry out the euthanasia, and the patient and his or her family agree with this plan, we can complete the action. However, on the other hand, if the patient decides that he is terminal or she is terminal, but requests against euthanasia, then the patient should be allowed to carry out their end-of-life care at home with their loved ones. So the last step includes reflecting on our decision, whether it be using the UK model or the US model, and we can ask ourselves a couple of questions to see how well our action improved or decreased the patient's quality of life. The first question includes, how did the end-of-life care decision impact the patient's quality of life? And was using one model, whether it be United States or the United Kingdoms, better than the other model? And if it was, we should probably implement more of those ideologies into our end-of-life care. Lastly, this is probably the most important part, which is what could be done differently to improve the patient's quality of life, which is probably the most important part of the end-of-life care. Thank you, and we hope you enjoyed our presentation.
Good.
And these are our references.
Yeah, you can delete these are references.
Okay, we're done.
We're done, yeah. So as long as you
That was good. That was good. I like this one.
So transfer.
Did I say patient twice?
Yeah, but
You
it's
said
fine.
that, I was like, it's okay.